look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
But if we just take a step back, there's a whole bunch of cardiomyopathies. There's a number of things that affect the heart muscle. Some of them are intrinsic to the heart muscle. There is a gene abnormality or a virus has affected the heart muscle. And sometimes it's things that affect the whole body, what we call systemic diseases, but it also then happens to attack or affect the heart muscle itself. Some of these things are isolated, it's just the heart muscle that's affected, and some of them, you'll have muscle issues, you'll have eye issues, you'll have other things that are going on. So our classification of cardiomyopathy is heavily based by what we see when we look at the heart, as opposed to necessarily what's happening when you look at just the pathology, but also it's guided by what is driving that process. So cardiomyopathy, cardioheart, myomusculopathy, disease of, and then within that, there's a number of classifications. And at a very simplistic level, you can think of it as the heart being big and thin, or you can think of it as being small and thick. So thick is often hypertrophic cardiomyopathy, where the heart size is small, and then thin is where it's dilated cardiomyopathy, the heart muscle has enlarged, it's thin, it's become baggy, it's not working well. But then beyond those classifications, we see a number of other conditions, some of which are called restrictive cardiomyopathy, that I'll explain in a moment. But effectively, one can think of the heart as really being very stiff. The underlying factor there is that the heart is stiff, the heart should be beating like this, and it beats reasonably well, but it's just not expanding. It's like a fresh balloon. You're trying to blow into it, and it's just really hard. So think of it as a stiff heart, and therefore it's causing back pressure in other areas. And then you have the unclassified category, which is basically, we're not quite sure where to put it. And sometimes left ventricular non-compaction, where the heart's very spongy, and Takotsubo, the so-called broken heart syndrome that I'll explain in more detail, can be categorized into that. The other thing that's changing is our understanding of why these things are happening. So 10, 15 years ago, dilated cardiomyopathy was just a bit of bad luck, it was random, and now increasingly we're realizing that there is a predisposition. There's genetics, there's environmental factors, and sometimes it's not just genetics and not just the environment, but it's sometimes when the two come together, what we call a second hit that unmasks the disease state. And so our understanding is evolving all the time. So although we have this classification, this is being updated as we understand more about the condition and think more about it. And so bear in mind that this is a working classification for the diseases based on what it looks like, what we call the phenotype, what does it look like literally when you look at the heart, and then is it genetic, non-genetic, and then what are some of the other drivers that are classifying it. So restrictive cardiomyopathy. So what is restrictive cardiomyopathy? So there isn't an absolute classification. I'll give you the medical speak for how we define it, but then I'll describe it in English. So distinct hemodynamic morphological characteristics, severe diastolic function with restrictive filling patterns, elevated filling pressures from increased myocardial stiffness. What on earth does that mean? Okay. So basically, the heart muscle is stiff, and therefore, because it's stiff, it can contract well, it can squeeze well, but it's just not relaxing back to its old stage again. And because it's not relaxing, that's causing back pressure. If the heart's trying to fill the heart muscle, if the upper chamber is trying to fill the lower chamber with blood, and it's just not sort of opening up well enough, it means that you're going to cause back pressure. You're going to cause back pressure in the upper chamber in the heart, but because the heart's connected to the lungs, you're going to get back pressure in the lungs. Because the lungs are connected to the right side of the heart, you're going to get back pressure on the right side of the heart. So that's what it means, where hemodynamic just means pressure assessments. So severe diastolic function, that means the relaxation phase. So the heart's pumping like that, that's called the systolic phase. And then the diastolic phase is where it's relaxing to fill up again. So the diastolic phase is just very stiff. And restrictive, it just means something, literally something is restricting it from springing open. And the elevated filling pressure simply means that because it's stiff, you're causing pressure to build up in all the things that are connected to that chamber, and resulting from myocardial stiffness, that fresh balloon, that balloon that you're trying to blow up and it just doesn't open until suddenly, boom, it opens and your cheeks go all over the place. And generally, unlike some of the other cardiomyopathies, generally the squeeze factor, that bit, what we call the systolic function where it contracts, is generally good. It's not that this is an impairment that the heart is stiff and it's just not doing anything. Generally, the contraction is good, so it's pumping the blood out, but it's just the relaxation phase as it's trying to fill up again becomes very difficult until advanced disease. Yeah? So systolic function, the contraction phase, and the size of the heart is usually normal or only mildly reduced until advanced stages of the disease. Okay? So restrictive cardiomyopathy, stiff, not contracting well, but just not opening up. It can affect all four chambers in the heart, but particularly the left side. But because you're causing back pressure, what's connected to the left ventricle? It's the upper left atrium, and therefore the atrium is going to become big. And so one of the hallmarks of this condition is that when you do an echo, when you do an MRI scan, the heart seems to be contracting well, but it's often a little bit thick, but your upper chamber, it's not relaxing well, and your upper chamber is huge. It's huge because that back pressure is causing it to enlarge. Yeah? So atrial enlargement due to increased atrial pressure, that pressure buildup. And then just to add to the excitement, there's a lot of causes. There's a number of things that can cause this, and therefore restrictive cardiomyopathy is an umbrella term. But let me talk you through this. It's a busy slide, but I'll talk you through this. So one is an infiltrative process. So this is where stuff has come into the heart muscle, proteins have built up into the heart muscle, making it very stiff. And the classic example of that is amyloid disease, where you have proteins that are being produced in the bone marrow and other different cells that are traveling into the bloodstream, they're accumulating into the heart and making it very stiff. Yeah? And then you have other things, you have enzyme disorders. So patients are born with an enzyme disorder, and instead of making proteins in a normal way, enzymes in the heart, but also in other cells in the body, are abnormal, and therefore proteins are building up. Proteins are building up, or the wrong kind of protein is building up. An example is Fabry's disease that I'll talk about in a moment. Or occasionally, the body isn't able to process iron. Red blood cells need iron to function. They transport oxygen all the way around the body, but occasionally patients have gene defects, and these ions, or the iron processing, the way the iron pathways are abnormal, and therefore you get abnormal iron accumulation depositing into the heart in other muscles, and therefore you get something called haemochromatosis, blood cells iron accumulation in the heart muscle. So haemochromatosis, and these are what we call storage disorders. Stuff is building up, it's not escaping, the heart's becoming stiff. And then we can think of genetic disorders where there are gene abnormalities that are affecting not just the heart muscle cells, but they're resulting in increased scar tissue forming around the heart muscle. So you've got your muscle cells, they're contracting, but if you didn't have a scaffold for them to sit in, they'd all be swimming around in the bloodstream. And so to keep the heart as it is, and to keep the heart and the heart cells in place, you have a scaffold called fibrosis tissue, or collagen matrix, that's around all of these heart muscle cells, and these keep the heart muscle cells literally in the heart. But if that matrix becomes very thick, or there's abnormal buildup of fibrosis in them, then suddenly these cells can be contracting, but again you have that stiff balloon syndrome. The heart's becoming thick, the scaffold isn't allowing these cells to do what they need to do. And increasingly we're realizing that these are not just random things, but they're often because of a gene abnormality, and so a genetic thing. And then you have non-genetic causes. So radiation, we've had amazing successes in treating cancers, for instance, but now we're realizing that some of these therapies, particularly the old hybrid dose radiation therapies, are resulting in this increasing scar tissue building up in the heart. The heart muscle cell doesn't like radiation. The heart muscle cells, or the heart produces abnormal amounts of scar tissue around these heart muscle cells, resulting in stiffness of the heart muscle. Okay? And so one of the things that we always look at and question in our patients is, have they had lymphoma, for instance, when they were young? In the old days, they may have had a lot of radiation therapy, or more recently, they may have had chemotherapy. Again, anything that irritates the heart muscle will result in the heart saying, don't like that, building up more scar tissue, fibrosis around the muscle cells, the heart becomes stiff. And then there are subsets: diabetes, poorly controlled, long-standing diabetes. Again, it's the high blood sugars are affecting the heart cells, therefore you're getting scar buildup. And then a condition called systemic sclerosis. So a lot of patients with rheumatological conditions will often present with heart problems because, again, the heart's being irritated in a sense, and although the muscle cells may be okay, the scaffold around is becoming abnormal. And then you have some rarer conditions where you have abnormal blood cells called eosinophils that have a role in the bloodstream. They do various things. They help against infections and other things. But occasionally, the body's systems, the bone marrow, etc., can go into overdrive and produce too many of these cells. They then accumulate in the heart, causing the heart muscle to become stiff, to become thick, a condition called endomyocardial fibrosis. So I'll go through all of those as we chat. Please do. Yeah.
My grandson had cancer as a child twice.
I'm so sorry.
My grandson had cancer as a child.
Right.
Twice before the age of 2.5. Quite an aggressive one.
Sure.
Neuroblastoma. So the treatment was very aggressive.
Sure.
Obviously, it was under the margin. Obviously, they did regular heart tests.
Yeah.
He's now 22. So this was when he was 2.5, 3. He had tests up until he was about 17, 18. And now he just doesn't want to know about it.
Sure.
If the heart was going to react, as you say, would it be done so by his 18?
So usually within 10 years or so. But we are appreciating that sometimes these can be very chronic changes as well. So it's not a bad idea. Again, what you don't want to do is medicalise a 22-year-old bloke who's more interested in Arsenal going to win the football this weekend rather than coming in. So two things. One is that every few years it's not a bad idea to get it checked. And secondly, if he completely disengages, you as his grandmother just threaten him and say, I'm going to get my tongue pierced if you don't go and get your heart checked. It works a treat. Yeah?
Okay.
Sometimes you have to be radical, yeah? And I'm going to war-torn jeans, okay? So you just got to, you can do all the, you really need to get this checked. Yeah, whatever. No. Good. Well, there you go. It works a treat. Okay, so this just highlights, again, I won't go through all of these things. I'm very happy to go through specific conditions in the questions section, but it just highlights that there are different things that cause the heart muscle to be stiff. It's an umbrella term. It's not a one thing fits all. So let's just look at some of the key examples. So these are the more common ones that are causing restrictive cardiomyopathy. So amyloid disease. So amyloid disease is where you get abnormal protein buildup, fibrils, in the heart muscle. There's about 20, 30 different causes of this, but these proteins are building up in the heart muscle, often because of changes in the bone marrow, but occasionally it can be genetic. And because these proteins build up in the heart muscle is thick, it doesn't thicken well. You can see that there is buildup of fluid. So let me orientate you as well. So we're looking at 4 chambers in the heart. This is a cardiac MR scan, 4 chambers of the heart. This is your right atrium, so blood's coming in through the veins, into the right atrium, into the right ventricle. The right ventricle pumps the blood into the lungs, picks up oxygen, goes to the left side of the heart, the left atrium, and then into the left ventricle. The left ventricle being the powerhouse of the heart that pumps the blood all the way around the body. And under normal circumstances, the left ventricle should be up to about 12 millimeters, 8 to 12 millimeters is normal wall thickness. And although you may not appreciate it here, the wall thickness here is about 15, 16 millimeters. It's very thick. It's much thicker than normal. And what you're seeing here is a lot of fluid buildup in the lungs. So the lungs should be full of oxygen. This is healthy, normal lung tissue. And the whole of this area should be lung tissue, but instead it's filled with this white stuff, which is fluid. Yeah, and for those of you that are interested, this is not a donkey inside his right lung. This is his lung just filling up with fluid. Yeah, I have been asked that question. What's going on here? Is this an animal there? But massive fluid buildup because of that back pressure. Therefore, the lungs aren't working properly. And again, just looking at this in another heart, in another angle. And so when you cut through the heart, and these are cardiac MRI images, what you're seeing is that there is what we call concentric thickening of the heart muscle. The whole muscle is thick. It's like a big polo. And again, you're getting fluid around the heart, which is pericardial effusion. You're getting that massive buildup of fluid in the lungs. Now, how can we diagnose this condition? Well, one of the best ways is A, presentation, but B, is by using cardiac MR imaging. And what we do is we use a contrast agent called gadolinium. And gadolinium is a compound that's taken up in areas where you have gaps between muscle cells. And when we give the contrast agent, there are very different patterns on an MRI scan that help us to understand what the underlying etiology would be. So this is an example of a heart where a patient has had a heart attack. We've given the contrast agent. Normal heart muscle has this grey charcoal appearance, but in an area where they've got a heart attack, you see this bright white scar area over here. And you get scarring on the inner side of the heart because this is the area that's most affected when you get a blockage in the blood vessel. In hypertrophic cardiomyopathy, so the hypertrophic cardiomyopathy is where the heart muscle is very thick, but it's because of a gene abnormality. It's not a form of restrictive cardiomyopathy. It's a gene abnormality where the heart's become thick, but where you have thickening of the heart muscle because of an underlying genetic cause. You get thickening, but it's usually one area of the heart muscle that's thick rather than the whole muscle, and you get this patchy kind of fibrosis. So this white area represents scar tissue that's occurring in random areas, but usually where the heart muscle is thick. By contrast, in amyloid disease, what we see here is that the heart is almost concentrically, almost circumferentially thickened. And when you hold the heart of a patient or the explanted heart of a patient that's had amyloid disease, your hand just goes like that. It's full of these protein fibrils. The heart's become very stiff. It's become very heavy. And these patients, therefore, get very breathless. They get fatigued. Their exercise capacity is reduced. And when you then look at under an electron microscope to see what's happening in the heart, so here you have a heart muscle cell, but you'll see that what we're appreciating here is that around that heart muscle cell, here's another one, you've got all of these strands. These are protein fibrils that are built up inside the heart muscle, making it very stiff. Okay, so and the reason why amyloid is important is a number of reasons. One is that when patients present, they can be very unwell. But secondly, there does seem to be a correlation with aging. So as we see more and more people, as we see an aging population, we're seeing a lot more amyloid disease. So in other words, there seems to be some correlation, a reactive change, and therefore a lot more 80, 90-year-olds are presenting with this condition, and therefore we need to be aware of it. The other thing that happens is that because the heart muscle is stiff, you can get clots forming in the heart. So the upper chamber is enlarged, blood isn't flowing normally, and therefore wherever blood isn't flowing normally, it can, like in a puddle where you get clots, where you get where it goes murky if water isn't flowing. In the same way, if blood isn't flowing in the heart normally, then it clots and you get these thromboemboli that can then cause a stroke. So it's important to recognize and important to identify. Again, there are specific tests that we look at. I won't go into the details here, but when you look at the heart muscle cells and you look at the heart tissue under the microscope, again you're appreciating the buildup of these fibrils and certain specific markers that allow us to diagnose this, something called Congo red staining. So that's amyloid disease, and I'll just one of the good news stories that we have here in terms of amyloid is that for the first time, because we understand now some of the causes of this, and in particular the fact that there is a subset that has a genetic predisposition, we can start to think about therapy. So this is where the research has made a big difference. So a number of new drugs have come onto the market now where in the subset that have a genetic cause for their amyloid, in other words, a gene has caused the proteins to accumulate and build up, then you can start to think about how can you block those proteins building up. And this is in a specific form of amyloid, so it doesn't apply to all of them, but a specific form called transthyretin amyloid, which we particularly see in Afro-Caribbeans, but also increasingly in an aging cohort. And this is exciting because if you can block the gene abnormality, or if you can block the poison protein from building up, you have the potential to make a difference. So this is an exciting area where the research is making big differences. And there's a couple of these therapies. This is one, and this is another. Both of these are really hot off the press, where you can take an antibody approach or you can use gene therapy to try and block those abnormal proteins. But it's only in one of the specific forms of amyloid disease. But it's a start. And as they say, the journey of 1,000 miles starts with a single step. So once you can start to make inroads, you can start to make a difference. So the other form of cardiomyopathy we talked about that we see not infrequently is hypereosinophilic syndrome, where one of the blood cells called an eosinophil accumulates in the body. The bone marrow goes into overdrive. It produces excess amounts of these cells. They then accumulate in the heart muscle. And again, you see certain appearances. So this time it particularly affects the right side of the heart. So the right side of the heart should be thin like this. And you can see that there's this wedge-shaped formation occurring in here. And this is a very classic finding that you see in hypereosinophilic syndrome. And the reason why it's relevant is that these patients are at risk of heart failure. But also because the blood isn't flowing normally in the heart, and because these eosinophils building up, you get clots forming. So again, fourth chamber of the heart, the right atrium, the right ventricle, the left atrium, the left ventricle. And this right ventricle is very thick. It should be thin like this. It's very thick. And because these cells are sticky in a sense, clots are forming, and these can then travel to the lungs, cause a thromboemboli, pulmonary embolus, or on the left side, causing a stroke. And then the final example that I'll show up of a restrictive cardiomyopathy is Fabry's disease. And in Fabry's disease, you have an enzyme abnormality. It's about 1 in 40,000 of the population will have this, so it's rare. But where you pick it up, it has a massive difference in terms of how you manage this. So we talked about the fact that these often have thick hearts. Whenever we see a thick heart, the commonest cause of a thick heart in the whole population is going to be hypertension. But then we'll have a subset that's hypertrophic cardiomyopathy, 1 in 500, and then 1 in 40,000 will have a thick heart, and it's not because of hypertension, it's not because of hypertrophic cardiomyopathy, it's because they have this enzyme abnormality resulting in abnormal protein buildup within the heart muscle called Fabry's disease. Yeah? It's what we call an X-linked serum alpha-galactosidase deficiency. And the reason why it's important is that there is now enzyme replacement therapy that can help to improve outcomes for these patients and their management. So picking up the diagnosis, it's not just a random thing or a nicety, it's understanding what's happened, why has it happened, what can we do about it? And again, heart muscle cells, they become empty, what we call vacuolated. There's very specific changes within these patients. And again, it's a thick heart, it's concentric, and you get a lot of scarring on the outer wall. It mainly affects men. It's what we call X-linked. So if you've got a family history where all the men are being affected and women very rarely, always think, could this be Fabry's disease? Your management is very different. And so briefly, when we think of a restrictive cardiomyopathy, again, very few patients will come with a sign on their head saying, I've got a restrictive cardiomyopathy. It's really, what is the presentation? So are they short of breath? Are they getting fatigued? Are they finding their exercise capacity is reduced? And then you do imaging, and you're finding that the heart muscle is often thick, or that or it's a normal size, but the upper chamber is huge, and it's contracting reasonably well, but it's very stiff in its opening. Yeah, and so the moment you see those kinds of findings, again, go through the history, go through the family details. Have they had radiation? Have they had chemotherapy? All of these things become important, and then trying to work out what's going on. And often, if we're unsure, a cardiac MRI scan is really helpful. If we're unsure beyond that, genetics and a biopsy occasionally can be really useful. And again, this just highlights some of those things. But again, the starting point is the wall thick? Is it not thick? What are the other chambers doing? What's the right side of the heart doing? And then to take from there. We switch gears now, and we talk about a very different condition now. So left ventricular non-compaction. So when the child is in the womb, in utero, what's happening under normal circumstances in the heart is that you've got an inner, in terms of heart formation, you've got an inner layer of cells and an outer layer of cells that coalesce together to form the heart muscle wall. Yeah? So what we call the subendocardium, the subepicardium. So inner wall, outer wall, the cells come together and they form the heart muscle. And that inner layer in utero is very spongy. It's very spongy because it's trying to absorb all the nutrients that it's getting from the mother's blood supply into the body, and therefore the inner layer is very spongy, whereas the outer layer tends to be compact. Yeah, and under normal circumstances, as the baby in utero is coming towards term, that inner layer that was very spongy starts to become more condensed, and the inner layer and the outer layer form a solid sandwich. And in left ventricular non-compaction, what's happening is that inner layer is not condensing. So it remains very spongy. Okay? And that's why it's called non-compaction. And here's an example. This is a true story. This is a 68-year-old gentleman who presents with shortness of breath and reduced exercise capacity. He gets an echocardiogram, and he's got a dilated heart, which is what often happens in this situation, and he's got a history of heavy alcohol consumption, and everyone says, oh, you've got an alcoholic cardiomyopathy, you need to stop drinking. And he protests, and he says, guys, I used to drink heavily in my youth, I've stopped drinking heavily for 40 years, sees a different doctor every time, and they always say, you need to stop drinking, this is an alcoholic cardiomyopathy, the heart's big, and you've got what we think is a clot in the heart, because there's lots of strands at the bottom of the heart, and he protests. And then he gets an MRI scan, which offers much higher definition. And what we see in his heart is that it's got all of these fronds. The heart muscle should be condensed like here, but instead you're seeing all of this network of what we call non-compaction or trabeculae that are sticking into the bloodstream. And for the first time, what you realize is that actually he doesn't have an alcoholic cardiomyopathy. He has this sponginess of the heart muscle. It's a rare condition, but he has this sponginess of the heart muscle that we see even better when we cut through the heart muscle, where the heart muscle is completely spongy. Yeah? It's non-compacted. And for the first time, everyone believes his story that actually he doesn't have an alcoholic cardiomyopathy, but he has this left ventricular non-compaction. Unfortunately, after being told that it can be associated with heart failure and clots, he becomes so depressed he starts drinking. But that's another story. Yeah.
I'm actually under you for LVNC, and we had a Zoom call a few months ago. Similar situation to your case, apart from the fact I'm not a drinker.
Okay.
But what I want to know is, if you're born with a spongy, and I wasn't diagnosed until I was 60, how's the heart coped all those years?
So very good question. So again, without sort of taking a personal example, sometimes it can be because the amount of sponginess is in the milder end of the spectrum, so the rest of the heart copes. And sometimes it can be because that although the bulk of this is genetic, occasionally the heart can take a hit downstream, and then it manifests like this.
A hit from what? Stress?
A virus infection or a genetic abnormality that hasn't kicked in till much later.
Is that why I've never won any school races? Is that why I've never won any school races?
Absolutely, yeah. So exactly. So the commonest cause of this is that it's a congenital abnormality. It's something that kids are born with, but occasionally we are starting to realize as well that certain genes that may not kick in until you're 30, 40, 50 can then manifest. And because you always have two sets of genes, one from your mum, one from your dad, the good gene can be the dominant one, but then at some point the bad gene kicks in, often because of a virus or chemotherapy or excess alcohol or pregnancy. That can then kick in and then cause the heart muscle to become abnormal. So then as a response to that stress, the heart muscle dilates and it becomes spongy. But the commonest cause is usually where there has been a defect in birth. So very, very spongy. And because it's very spongy, what's happening? So first of all, the heart becomes big and dilates, so they present with heart failure symptoms. And secondly, because it's very spongy, blood can't flow normally within the trabeculae, and therefore you can get clots forming. So where it's very heavily spongy, and especially where the function is down and it's spongy, you always think about, do these patients need blood thinners? Again, just different examples. And the more we see of these patients, the more you realize that there is a spectrum. It's not a binary thing where it's either very spongy or it's completely normal, but you can see a whole spectrum of these, and sometimes they can be difficult to pick up. But there are criteria for how we diagnose these. Again, I won't go into the details, but happy to do so in the discussion, which relates to the ratio of how much trabecular lead you have versus how much solid lead you have. And there's a ratio, and there's different criteria, one of which is called the Jenni Criteria. But here's an example where it can be difficult. So is this non-compaction or isn't it? So you've got some trabecular, but it's in a localized area. The rest of the muscle looks thin. So is this non-compaction or is this normal heart muscle? So where it only affects one or two areas in the heart, we tend not to call it non-compaction. For it to have a diagnosis, you really want several areas, multiple segments in the heart muscle to be affected to really clinch that diagnosis. And again, an example here, because the blood isn't flowing normally, again, you see within that ventricle, you can see clots forming. So always think, if the heart function is down, do they need a blood thinner to be on? The other thing that can happen in these patients is that they can get scarring in the heart muscle. Over time, there is a reduction in blood supply to those spongy fronds, and so you can get scarring, which is one of the reasons for them presenting with rhythm disturbance, but also with heart failure symptoms. And when we look at the explanted heart, again, what we're seeing here is that the heart muscle should be fairly solid, but you can see here how it's got that spongy network, which reflects what you're seeing within the heart muscle. And then the final cardiomyopathy that we'll chat about is called Takotsubo cardiomyopathy, or what's called broken heart or stress-induced cardiomyopathy. This is relatively uncommon, but Takotsubo, what does Takotsubo mean? Does anyone know what Takotsubo is? So Takotsubo, here's a bit of Japanese for you, means an octopus pot. And the reason why it's called Takotsubo is that this was a condition that was first identified in Japan. And what's happening in this condition is that usually because of a very stressful effect, emotional stress, or someone's had a very bad reaction to a drug, something like that, the heart just literally goes into spasm. Yeah? It goes into spasm. And in a very specific way, and the upper portion of the heart is contracting, but the lower portion of the heart becomes very dilated. It almost becomes stunned. And an octopus pot, it has the same shape. So it's got a thin neck, and then it's got a wide bottom to stop the octopus from escaping. And so in that same way, what's happening here is that your muscle is contracting well at the top, but it becomes very baggy at the bottom. Because of that stunned reaction. Okay? So under normal circumstances, the heart should have that sort of pyramidal shape, and in this condition, the bottom portion of the heart becomes very enlarged, reflecting what an octopus pot looks like. So it comes under different names, so broken heart syndrome, stress-induced cardiomyopathy, and every now and then you'll hear of someone where they've had a major emotional stress, they've had an argument with their husband for not putting out the bins, whatever, and then suddenly they present with chest pain, they present with shortness of breath, they may get a rhythm disturbance, and when you look at their heart, the heart's gone into standstill on the echo. And in these patients, it can often mimic a heart attack, because they're presenting with chest pain, because the heart's not working well. And so with these patients, they're usually above the age of 40, 50. So you'll do an angiogram, you look at the coronary arteries are completely clear, and yet the heart's not working. And so if you see that shape, that's a classic example. But for some reason, and reasons that we don't fully understand, it seems to be much more common in postmenopausal women. And so if you have a postmenopausal lady that's coming in with chest pain, with classic features of a heart attack, but her coronaries are completely clear, and you've got this ballooning of the heart, always think, could this be a Takotsubo? So emotional stress or reaction to medication, those are the common things. We don't know quite exactly why it happens, and again, I won't go through all the details of that, but there's thought to be a surge of catecholamines, a hormonal surge, or that the coronary arteries go into a spasm, so the heart muscle stops getting enough blood supply, making the heart muscle kind of say, look, we need more blood, we're not getting enough blood, and therefore it goes into standstill. Those are the common things that occur because of this. Usually, the good news is that the majority of patients are therefore going to do very well because it's an acute hit, the heart's become stunned, but the majority of patients are going to recover. So when we see these patients, there's a number of things that you ask. One is there any blockage in the coronary arteries? they'll have an angiogram, coronaries are clear. Secondly, have they had a stressful insult that may drive it? And then the third thing is remove whatever may be the trigger. So occasionally it's because they've had a drug reaction, so make sure you've dealt with that, remove whatever stress is causing that, and then it's supportive therapy. So make sure they've not had cocaine or any drugs, particularly in a younger patient, that can also cause coronary spasm. So once you've excluded those things, then it's usually supportive therapy. So making sure their blood pressure is good, making sure that the chest pain is dealt with, rather than anything beyond. A small number of patients can develop heart failure. So again, if they've developed heart failure, we make sure we're addressing that side of things. A very small percentage with this condition do badly. So you hear of someone that's had a very emotional episode and then they've suddenly collapsed and died. And sometimes it's because they've had a heart attack, but it's sometimes because the heart's stunned. It goes into rhythm disturbance, it's not pumping around the body, and therefore they can die of what they call the broken heart. So classically, you'll hear of a 90-year-old patient who's passed away, and within a day or two of hearing that news, their loved one, their spouse, has suddenly collapsed and died as well. And often it's because of this, that emotional stress. So the percentage, the majority of patients can be absolutely fine, but the subset that make it into hospital, 3 to 4% will have a bad outcome, but the majority, over the course of the next 2 to 3, 4 weeks, will recover. And so when you re-image them after a month, heart's completely normal, and they do fine, the majority. So my final slide then, we've covered a broad range of things. Whilst you have very clear categories with hypertrophic cardiomyopathy, dilated cardiomyopathy, we're much more in this realm where our understanding is evolving over time between the restrictives, with the exemplars being amyloid and Fabry's disease, and then the unclassifieds, where we're learning more and more as we go over time. And when you look at this slide, if we were to re-look at what this looks like in 2035, this would be a very different slide because our understanding is going to evolve. I thank you very much for your attention.
Just testing, yes. I'm very happy to take questions for Professor Prasad. Happy to come to any of you. Yes, so, thank you. But just before I go into the app, any questions and does everybody know how to use the app? Oh, sorry, yes.
I didn't either, you're in good company.
Thank you. It's the first time I've come up against a HCN non-compaction, and I'm wondering, I've been told that I have left ventricular hypertrophic cardiomyopathy with provocable outflow tract obstruction. Would that come into the HCM?
No, so you would fall into this category with that we would call hypertrophic cardiomyopathy, and often because of a gene abnormality, rather than the restrictive cardiomyopathy, where the heart muscle is usually thick or just usually thin or just mildly thickened with a very specific pattern. So if it's hypertrophic cardiomyopathy, you fall into this end of the spectrum, rather than the restrictive cardiomyopathy end of the spectrum.
With the non-provocable outflow tract obstruction, which
can
be problematical.
What that means is if you think of a garden pipe, when you switch the tap on, you water the garden, the water comes out like that. If you stick your thumb on the pipe, then it comes out as a jet. So the left ventricular outflow tract obstruction means that the muscle, because it's thick, is a bit like the thumb on the pipe that's causing turbulence of the bloodstream and impeding the outflow of blood as it tries to leave the heart. And again, it's causing back pressure, and if there's not enough blood, it can make you feel dizzy, feel faint.
That's what that means. I do. Yeah. So would that also be why I have atrial fibrillation? Would that?
So because it's causing back pressure, what it's doing is it's causing back pressure on the upper chamber, the atrium. So the atrium is becoming enlarged. And if you think of the normal electrical pathways, what's happening is that you have an electrical signal at the top of the heart that goes to the middle of the heart in the atrium and says, hey buddy, lower chamber, start beating. And it sends out a signal. And when you're exercising, it's sending out more signals. And when you're resting, it's sending out less signals. But there is a pathway. in the atrium, the top of the atrium, connecting to the lower part, the ventricle, that's sending a signal. It's going from A to B. And what's happening is that because the atrium is so enlarged, that pathway is going all over the place. So signals are being sent, but they're going all over the place, and instead of going directly like that. And that's why atrial fibrillation occurs, because signals are coming out randomly. Does that make sense? And so part of the treatment may be to look at where these abnormal pathways are, try and zap them so you restore the conduction from A to B. So they may talk about, do you need an ablation, or they may try drugs to suppress these extra pathways that are occurring and just keep it literally from A to B.
Lovely, thank you. That was very helpful, the analogy of the tap and the pressure. Thank you.
Perfect, thank you. Yeah, again, time didn't permit, but within non-compaction, you can get your commonest form is in utero, where the heart muscle doesn't become spongy. But what we also realize, and this comes back to, I think, your point, which is that sometimes it can develop in later conditions, and sometimes it can be a spectrum of other medical disorders. So we will sometimes see in muscular dystrophy, we'll see it occasionally after pregnancy, and we often see it in patients that have what we call congenital heart problems, where the right stuff isn't connected to the left stuff, your hip bone's not connected to your whatever. So where there are different connections, or the valves have become very abnormal, so it can be a spectrum of that. So commonest is a developmental issue, but in a subset, it's very much part of a spectrum of other conditions as well. But the management is effectively the same.
I've got restrictive cardiomyopathy.
Mm-hmm.
So it's under control with various beta blockers and
Yeah.
how would that show itself in 10 years' time? So I'm being sort of cared for, if you like, by all the drugs.
So
if you move on, what
yeah. So two things. One is it depends on which cause of restrictive cardiomyopathy. So if it's what we call idiopathic, where the doctor is the idiot and the patient has the pathology, because we don't know what's causing it. So if it's idiopathic as opposed to amyloid or Fabry or anything like that, then the things that we would look for is, does the heart start to, it's stiff at the moment, but over time, does it start to become weak as well? So if you get heart failure symptoms, you're breathless, reduced exercise capacity, you're starting to build up fluid, that can be a long-term consequence. And then because the upper chamber is getting enlarged, are you getting atrial fibrillation? Are you getting other rhythm disturbances? And so when you go into atrial fibrillation, because the heart's beating like that instead of like that, you're losing 30% of the heart's efficiency. Something like 30% of the heart's efficiency. So if you get atrial fibrillation, some patients can tell you like that, they've gone into AF, because suddenly they can walk and suddenly they can't. And some patients, it's a gradual insidious thing. But if you get atrial fibrillation, again, do you need to zap the heart? Do you need drugs to slow the heart rate down? Do you need blood thinners? These all become part of the thing. So reducing your risk of heart failure and reducing your risk of rhythm disturbance are the priorities. And then understanding the cause. Yep.
Any other questions in the room?
Thank you. I also suffer from restrictive cardiomyopathy with permanent AF. There's been some discussion about the cause of this. Now, I see in your presentation earlier, I'm sorry I had to nip out, furosemide was working on me. Is use of lithium still regarded as a possible cause of restrictive cardiomyopathy?
So I would be honest and say I'm not aware of that as a sort of common cause. The answer is it could be, but it's not something that I would really identify. If I see a restrictive cardiomyopathy, that would be low on the radar in terms of potential causes. You never say never, but my thinking here is that I would be looking for other causes before ascribing it to something like lithium.
Right, that's quite interesting because I came to this conference, I think 5 years ago, 2018, and lithium was mentioned, and that really got my antennae working.
And this could be my ignorance. I will happily offline double check, because that's a very specific question. It's not one I've come across, but no. But happy to feed back to you directly.
I'm a bit like a fox terrier with its prey. I just want to understand what has caused this. And my first meeting with a cardiologist wasn't terribly helpful. Her opening gambit was, you have a history of bipolar. Well, I did not have a history of bipolar. Yes, I was treated for depression with antidepressants, and there's information in my medical records from a consultant psychiatrist confirming that. So I would still like to really get to the bottom of this question. And looking back, there have been other issues in my life pre-lithium that maybe have caused it. I don't know. Illness,
I think I would be honest. I mean, if you think of how many patients, mental health is such a big issue. Antidepressants are very widely used. Bipolar is common. We just don't see these patients coming through after 10, 15 years with a history of depression, now presenting with a restrictive cardiomyopathy. So my initial thought would be, I would be thinking of other causes before ascribing it to that.
Right, that's quite interesting. I shall continue digging.
Yeah, no.
Thank you.
No, please.
So many cardiomyopathies, so many causes. I've got very, very low EF. I'm on the 4 pillars. Other people do the same as me and they can raise their EF.
Yep.
Is it because mine was in your utero that it's harder to raise it?
So the answer is it's a great question, and it's a very difficult one to answer, because if we look at our population, for example, that present with heart failure due to a cardiomyopathy, about 15%, their heart function will completely go back to normal once they're on treatment. About 15% will do what the pejorative term is called crash and burn. They will deteriorate, it'll be really bad, they're very symptomatic. And then you've got about 70% where there will be improvement. And it's a spectrum from a little bit of improvement to a lot of improvement. And so come back to this. So things that seem to be a driver is, number one, why? So is this a gene abnormality? And in other words, is the body producing abnormal protein? And then is it a big gene abnormality? In other words, you're producing lots of toxic protein? Or is it a small end of the gene where it's just a little bit abnormal? So the gene abnormality is important, but also so is the environment. So if you've got someone who's a heavy drinker, they're smoking excessively, or they've had chemotherapy, that makes a massive difference as well. So everyone is very individual, but it all comes down to the root cause. And so one of the studies that we're doing now is we're looking at our cohort to try and understand what are the determinants. But certain things stand out. The gene and the cause, the gene is a really important thing in that. And that would explain why you get variation. But it's not just the gene, because you look at family members and you've got a 70-year-old patient who's running the marathon with the gene, and then you've got a 15-year-old who's on the transplant list. But they've got the same gene, and therefore the environment and what we call epigenetics, things that are switching on or switching off that gene, also play a role as well.
Sorry.
Thanks very much. Thanks very much for all these questions. Have been fantastic so far. Somebody was diagnosed with left ventricular non-compaction about 2.5 years ago. By what they think is family genetic, but it's unidentified at the moment through testing. How can I put this? I'm looking at somebody who was told at a very early time that your life expectancy was 5 years and frightened the life out of me. I seem to have it in the back of my mind waiting for this decrease, because I was somebody with a really low EF that just crashed and burned, and then with the medication, the 4 pillars, it's really improved. And I have days where I feel that there's nothing wrong with me, but then I have other days where I just crash and burn and I just can't get out of bed, and I get quite symptomatic. I keep looking for when is it going to when is this downturn in my life going to be? Recently, I've been getting low pulse rate, very low, quite low, and I've got different. And I was wondering, are these the sort of things that it starts with, the downturn?
So usually any downturn is gradual.
Right.
And the other thing that to factor in coming to your 5-year survival is that is this is not a doom and gloom story.
Right.
You know, this is not a doom and gloom story. The drugs that are now coming on have had a massive transformation. So the prognosis that you may have been given is untreated and without medication. But in the last 2 to 3 years, there have been some amazing drugs that have come onto the market, and things like SGLT2 inhibitors, drugs like Entresto, that have really transformed for patients with the dilated heart, so not the hypertrophic, but the dilated heart and the non-compaction, that have really transformed the outcome. So usually it's much more of a gradual deterioration rather than an acute deterioration. So, you know, so I would tell patients, don't wake up and think, oh my goodness, today it's gone into heart failure. The circumstance where that could happen is if you've had a rhythm disturbance and the heart's thrown a wobbly and then it's suddenly stopped working effectively. But in the absence of that, it's usually a much more gradual thing, unless a rhythm disturbance or unless a severe viral infection has just hit the heart. And then the slow heart rate is that simply because you're super sensitive to drugs like beta blockers. Great drugs, but they can slow the heart rate down, and that too can make you feel quite tired and breathless. So it's not all necessarily a deterioration. So the key there is surveillance, monitoring. What's the ejection fraction? What's happening in terms of rhythm disturbance? What's happening to blood markers? Something called a BNP or NT-ProBNP is a very good way of telling, you know, is the heart under strain or is it coping well? Does that answer the question?
That's great. Thank you very much.
Thank you.
Can I ask you just a little bit more about the haemochromatosis link? I was actually found to have that quite some years ago, so quite high numbers that kind of came out of nowhere. But that was kind of never considered in terms of the heart. So should I be flagging up to my cardiac consultant about the haemochromatosis and...
Sure.
Yeah.
So again, it's a spectrum. So there will be patients that have a little bit of iron accumulation, and then there'll be patients that have a lot. And generally, the restrictives are where you've got a lot of iron accumulation, so patients that have had multiple transplants, or patients with a condition called thalassemia that we see a lot of in the Mediterranean, where there's big gene defects. So the answer to your question is I'd just get them to check your ferritin, and if it's super high, so I'd get them to check your iron profile, and if it's super high, just raise with them, could haemochromatosis be a cause or an explanation or a contributory factor to what's going on? And again, the relevance is that the treatment is different for that.
Okay, thank you.
And if it's a little bit up, it's probably unlikely, but if it's a lot up, then that should be looked into.
Okay, thank you.
A quick question that was posted a few minutes ago is, I was diagnosed with LVNC in 2020, and I now have an ICD fitted in 2023. My EF is 25. Will that improve with the meds I am on?
So again, the answer comes back to those statistics. So about 30 to 40%. 30 to 40% will increase very significantly, 15% back to normal, 30 to 40%, a lot of improvement. But in the majority, or in the other half approximately, it will improve a little bit or deteriorate. So it's a hard one at the moment to know on a personal level. We can look at a population, but for an individual, the things that indicate that they're probably going to do well is how bad is the cause, and are they on all the right drugs, and is there a lot of scarring? So if there's a lot of scarring in the heart, it means that the heart muscle cells have been replaced by scar tissue, so they're less likely to do well. If they haven't got scar tissue in the heart and the heart's spongy but not scarred over, they're more likely to do well. And then is there a genetic basis for it? These all play in.
Yeah. Thank you.
Sorry?
There's no genetic, I've had genetic screening, there's nothing
Good.
that they found, so they've asked me to
Great. Okay. And then is there, if you've had an MRI scan, is there a lot of scarring? So if you've not had scarring, again, that cohort tends to do better.
Yeah. Thank you very much. Another question is, regarding LVNC, I know it's one of the rarer ones, but is there any consultant in the country that specializes in it?
Yep. So because it's relatively rare, I'm not aware that there is a one person that kind of sees all of them. But generally, the patients that are seeing dilated cardiomyopathies tend to have an interest, a sub-interest in this. So, for example, at the Brompton, one of the groups that's done work on it is Sabi Gatti in our group. Myself, I have an interest. At Bart's, Perry Elliott's done a lot of great work in this. So Bart's, the Brompton, they have a special interest in LVNC, and at St George's as well. Those are the three places that stand out that have a special interest in this.
What's a good BNP reading?
So there are two types of BNP. So one is called NT-ProBNP and one is called BNP. So a good BNP is less than 100. A good NT-ProBNP is less than 400.